This is UC Davis Thoracic Talk, where we demystify the patient experience and learn more about the care pathway for those undergoing surgery by our nationally renowned UC Davis General Thoracic Surgery team. In this episode, we discuss therapeutic clinical trials that are available to our thoracic surgery patients at our UC Davis National Cancer Institute designated Comprehensive Cancer Center. I am Dr. David Tom Cook, Chief of our UC Davis Division of General Thoracic Surgery. Dr. Jonathan Reese is a member of our medical oncology faculty and the medical director of thoracic oncology at UC Davis. Dr. Reese, thank you. Thank you for talking with us today.
It's a pleasure to be here. Thank you, David.
Dr. Reese, what is a therapeutic clinical trial, and what are the different types of phases of clinical trials?
So a therapeutic clinical trial in cancer basically enrolls patients on a clinical trial that provides a specific therapeutic treatment to study its impact on the cancer. And so we usually look at phases of trials. So phase one clinical trials are generally trials looking to establish safety and tolerability and early signals of, well, do we think it's working well in patients? And then a phase two trial takes that data and says, well, is there a further signal that this could really be beneficial to patients? And then a phase three trial is typically larger. And those are many of the trials you hear about in the news where patients are often randomized to what the best standard of care is or the new treatment to see if the new treatment is meaningfully better where it's worthwhile to replace the old treatment, because it's better in terms of helping patients feel better or live longer or delaying the time from the cancer to coming back or some other meaningful clinical endpoint that we think of as helpful.
Great. So although lung cancer is the #1 cancer killer in the United States and other thoracic cancers are challenging, over the last decades, we have seen an increase in survival and cures after treatment for lung and other cancers. There's data that demonstrates that the participation in clinical trials in of itself provides a survival advantage for patients, especially for those with lung cancer. One thought is that the baseline treatment, as you mentioned, for phase three clinical trials is standard of care. And some patients in this country have poor access to standard of care. So well-planned standard of care treatment is beneficial to patients. In addition, there has been an innovation explosion of what is called targeted therapy and immunotherapy, also called IO therapy, which are novel drugs to benefit patients. Dr. Reese, what is targeted therapy and immunotherapy, and how might these treatments benefit our patients with early stage thoracic malignancies like lung cancer?
So those are great questions, Dr. Cook. And what I would say is we've had just incredible advances in how we treat lung cancer. And those advances have really been magnified by targeted therapies and immunotherapy. And so targeted therapies are basically precision treatments that are different than chemotherapy, where we deliver a drug that specifically targets a cancer pathway that we think is overactivated. So I want to use an example. So in lung cancer, we are doing gene sequencing of lung cancers. And it's mostly not genes that are hereditary, that are inside the person, but are mainly inside the cancer. And some of them we find really drive the cancer growth. And that's bad in a sense that it drives the cancer growth and lead to cancer. But what's good is we've developed targeted therapies that turn that on switch off. And so we've discovered a number of mutations, one, for example, called EGFR, another called ALK, another called ROS1. Right now that there's 8 where we could match patients to precision targeted therapies that have very high response rates and clinical activity in terms of shrinking the cancer and controlling the cancer. That's different than chemotherapy because it specifically shuts down the pathway that's overactive, and not giving chemotherapy that also may often damage healthy cells and cause some of those those side effects that you hear about that may be related to chemotherapy. And so that's been really exciting and just been a tremendous advance in helping patients live longer, live better with lung cancer. And immunotherapy is, I would put, as another major advance that I'm sure many people have heard about in the news, and sometimes even on advertisements and so forth if they watch the NFL or other programs. But the main focus of immunotherapy is to activate your immune system to attack the cancer, because the cancer can sometimes express a protein that tells the immune system to go away. And these antibodies can unmask that and allow the immune system to better attack the cancer. And that's been shown to help patients with lung cancer, help many patients live longer. And what we're doing now, and what I think is really exciting, is saying, okay, well, we've really helped patients live longer with these treatments and live better with metastatic lung cancer. But can we cure more patients working with you with integrating these treatments with surgery in select cases to help better cure lung cancer? And that's what I'm really, really excited about working with you and our thoracic surgery team at UC Davis about.
So despite these amazing advances in, as you define as precision therapy or precision medicine, so targeted therapy and immunotherapy, some patients in California and the nation may not be benefiting from these incredible interventions. Women and patients of color, especially Black and African-American patients, are less likely to participate in clinical trials. In addition, Black and African-American patients are less likely to have their tumor undergo what is called molecular testing to determine eligibility for targeted therapy clinical trials. Some of these disparities in clinical trial enrollment by our underserved communities is a result of mistrust in healthcare. I've had patients of color tell me, I don't want to be a guinea pig. When we discuss opportunities to participate in therapeutic clinical trials that we have here at UC Davis. I myself was enrolled in a therapeutic clinical trial evaluating the COVID-19 vaccine early in the pandemic. And I found the protections and safeguards of that trial incredible and reassuring. Dr. Reese, you supervise many therapeutic clinical trials at our UC Davis Comprehensive Cancer Center. Please describe the many layers of safety and quality that protect our patients during participation in these trials and even afterwards. And what do we do here at UC Davis to build that trust between our patients and our clinical trials team?
So we have a real commitment to enhancing participation of underrepresented communities, and providing that safety and oversight and that confidence to patients that are thinking about undergoing a clinical trial. And some of the things that we do is there's multiple layers of rigorous oversight here at UC Davis, and also by the sponsors of the clinical trial and the government. In addition, we have study coordinators that work with our staff and myself at UC and you at UC Davis to make sure that everything is planned accordingly, that potential side effects are closely monitored, and frequent appointments oftentimes to follow up on how patients are doing. So, I am a proponent of clinical trials for many reasons. One of those reasons is the intensive oversight that is provided by our colleagues and staff and us at UC Davis Comprehensive Cancer Center. The other thing that excites me is we need to do a better job of this, of getting the word out, because as you brought up, the historical experiences of many communities in terms of medical treatment, and so I think getting the word out of that this could potentially be beneficial, be helpful, that we're providing cutting edge treatment, that we're finding new targeted pathways and new immunotherapy combinations, and that we could potentially deliver that to improve patient out, to improve how you do, but also, to have a frank discussion about, potential side effects, risks, benefits. And I would encourage everybody that's thinking about clinical trials to ask those questions to find out if a clinical trial is right for you.
Is that listening component, that transparency, component that all builds that trust. And so the patients can see the different layers of safety that stacks the cards in their favor. You know, we mentioned earlier about molecular testing. Molecular testing involves taking a tumor after placing a needle in it for biopsy and analyzing the tissue to determine if there are any mutations in the tumor that we can fight with a specialized targeted therapy drug. Traditionally, this molecular testing is done in tumors from patients with advanced stage lung cancer. But now, as you said, we have a special screening trial at UC Davis that does this molecular testing in tumors from patients with early stage lung cancer and helps us determine if a patient would benefit from a therapeutic clinical trial in addition to surgery. Dr. Reese, please define and talk about neoadjuvant and adjuvant strategies in clinical trials for early stage thoracic disease. And let's use lung cancer as an example.
So that's a great question, David. And so, you know, one of the things that I would note is that, you know, we have clinical trials to best deliver multimodality care for our lung cancer patients that are undergoing surgery. And so, in standard, you know, a standard treatment for patients that have certain types of resectable lung cancer, for example, ones with an adjacent lymph node that's positive, we know that giving chemotherapy can help patients live longer. And so, you know, in standard treatment up until recently, giving chemotherapy after surgery for those staged patients has been the standard of care. Now, adjuvant, that's an example of adjuvant treatment, which is giving treatment after surgery. More recently, we've had an enhancement on that standard of care in patients who express that immune marker that I was talking about before, PD-L1, where immunotherapy may work better in certain situations. There's been an approval of an immunotherapy drug called atezolizumab, when given after chemotherapy, can help delay the cancer from coming back. We're still learning and waiting to hear if it actually helps patients live longer. But the benefit in those patients for keeping the cancer from coming back was so pronounced that it got approved by the FDA. More recently, we've been moving towards neoadjuvant treatment. And neoadjuvant treatment is giving treatment before the surgery. And most recently, there was a clinical trial that was published called Checkmate 816 that gave chemotherapy and immunotherapy before surgery. And it showed that patients that got that had, once again, an improvement in the time from the cancer coming back compared to patients who just got chemotherapy. So analogous to that adjuvant trial. So we are increasingly using that as our new standard of care to best shrink cancer and help keep it from coming back in patients who are going for surgery, who have earlier stage lung cancer, but may also have other high-risk features that make them not the earliest stage. So like a positive adjacent lymph node or a lymph node in the center of the chest and so forth. And that's where we have our multidisciplinary tumor boards that can kind of review together, myself, Dr. Cook, other medical oncologists, surgeons, radiation oncologists, to best plan the optimal course of care, both for standard of care and to properly offer patients clinical trials who we think might benefit.
So let's talk a bit about multidisciplinary tumor board. So within a multidisciplinary tumor board are myself, my surgical colleagues, medical oncologists, such as yourself, Dr. Reese, radiologists, radiation oncologists, pathologists, and interventional pulmonary medicine, as well as social work and clinical research coordinators who know all the clinical trials. And within the tumor board, we discuss really complex cases. Can you, Dr. Reese, talk about what cases we discuss in tumor board and how that leads to the best care for our patients?
So that's a great question, David. You know, at UC Davis Multidisciplinary Thoracic Tumor Board, we often review our patients in a multidisciplinary setting, which, as you mentioned, includes thoracic surgeons, thoracic radiologists, thoracic pathologists, medical oncologists focused in lung cancer, radiation oncology, interventional pulmonology, to really talk about how to best manage in a multidisciplinary fashion complicated lung cancer cases. And many of the cases we discuss are patients who are going for surgery. And some of the questions we look at are, well, what stage is it, to make sure that we have the appropriate stage? Is the pathology what we think it is? Reviewing it with the pathologist, and then coming up with the multidisciplinary treatment plan. There are some lung cancers that could be just operated on with surgery, but there are others that are higher risk. For example, ones that have lymph node involvement, particularly those in the center of the lymph nodes in the center of the chest, as an example, where we really need to discuss what modalities, in addition to surgery, such as chemotherapy, such as radiation, and such as clinical trials with immunotherapy or targeted therapy, that may really meaningfully improve patient outcomes in terms of delivering the best care to our patients. And I have to say too, it's probably clinically one of the things I look forward to most during the week, in terms of talking about these complicated cases with colleagues, and really hearing the perspectives and reviewing the data and our clinical trials to come up with the ideal treatment plan for our patients.
And one thing that is unique about our tumor board within our UC Davis Comprehensive Cancer Center is that we have what's called a cancer center network, where some of our regional partners that are in rural areas can beam into our tumor board via virtual conferencing and discuss complex patients at their sites, and then really benefit from the expertise from our team.
Absolutely. I think that's, our cancer care network, and being able to work with our partners in Northern California to talk about patients, provide these recommendations, and to see if maybe those patients might be interested in coming to UC Davis for a clinical trial, for example, with one of the targeted therapies or immunotherapies we discussed. I think, once again, is something really that we could add to the care for patients in our region.
Great. Well, thank you, Dr. Reese. This conversation highlights the groundbreaking cancer clinical trials that are available to our thoracic surgery patients, where we offer state-of-the-art therapeutics and still maintain our quality and patient safety standards, and our relationships built on trust with our patients and their families. This is in keeping with our motto of equality of great quality. Thank you, Dr. Reese, and this is another episode of Thoracic Talk.